hypertension. Then we have the chronic hypertension here, which was before the 20 weeks or before pregnancy. If we have proteinuria and there is a resolution of proteinuria, but there is persistence of hypertension, that is preeclampsia superimposed on chronic hypertension. If there is no proteinuria, but there is persistence of hypertension after 12 weeks, that is chronic or prevalent hypertension. So we'll start with preeclampsia. So preeclampsia refers to the onset of hypertension on a previously normotensive woman after 20 weeks of gestation. So we have three criteria for the diagnosis of preeclampsia. One, we should have a systolic blood pressure of 140 or above, or diastolic blood pressure of 90 and above, and proteinuria of 0.3 grams or greater in a 24-hour urine specimen. It can be classified as mild or severe. The incidence is 5 to 15%. So the risk factors of preeclampsia, we have a history of preeclampsia, Black race, maternal age below 20 or over 35 years, low socioeconomic status. We also have the first pregnancy, obesity, diabetes mellitus, chronic hypertension, underlying renal disease, vascular or connective tissue disease, or a family history of pregnancy-induced hypertension. So we have the pathogenesis of preeclampsia here. There is abnormal cytotrophoblast invasion and spiral artery remodeling, which leads to placental ischemia, which leads to increase of plasma and placental factors, such as those, which leads to decrease of the plasma VEGF and PIGF, which leads to endothelial dysfunction. After that, it leads to release of those factors, ET1, ROS, and decrease of nitric oxide, which leads to increase of total peripheral resistance, leading to hypertension, or decrease of RBF and GFR, which leads to decrease of renal excretory functions that leads to hypertension. So the pathophysiology, we have several genetic and immunological factors, which have been mentioned in this flow chart. And then this defective spiral artery remodeling during pregnancy. We also have diseased placenta producing inflammatory proteins that lead to hypertension, vasoconstriction, endothelial cell dysfunction, then leading to end organ damage. We have a diagram here, which the placenta, we have the defective spiral artery remodeling. In the arteries or veins, we have systemic vasoconstriction and endothelial dysfunction. And in the liver, we have the HELLP syndrome. And in the kidneys, we have the proteinuria. So basically, this is about pathophysiology. The clinical manifestations, the first one is hypertension, which is the most important criteria for diagnosis of preeclampsia. How do you diagnose this? This is with a systolic blood pressure, as you said, of 140 and a diastolic of 90 in a woman who has been previously normotensive. The second one is proteinuria. Proteinuria of 0.3 grams must be present to make a diagnosis. Proteinuria is normally the last sign, and it is an indicator of fetal jeopardy. So proteinuria comes because of impaired integrity of the glomerular barrier and altered tubular handling of the filtered proteins, leading to increased protein excretion. The third one is edema and intravascular volume, the increase in intravascular volume. Most pregnant women have edema, whether or not they have preeclampsia. However, if there's sudden and rapid weight gain and facial edema, this is an indication of preeclampsia. The fourth one is hematological changes. We have increased platelet turnover and coagulation abnormalities. If you examine a peripheral blood film, you'll see schistocytes and helminth cells. The liver, the clinical manifestations involve the right upper quadrant or epigastric pain, elevated transaminases, and in most severe cases, subcapsular hemorrhage or hepatic rupture, which may represent the HELLP syndrome, which is hemolysis, elevated liver functions, and low platelets. In the CNS and eye, the manifestations may include headache, blurred vision, schemata, and rarely cortical blindness. Seizures, if there's a seizure in a preeclamptic mother, this now will change the tone to be called eclampsia. So histopathological correlates to include hemorrhage, petechiae, vasculopathy, ischemic brain damage, microinfarcts, and fibroid necrosis. So the blindness, which is related to retinal pathology, is due to the optical nerve damage, renal artery spasm, retinal ischemia, and it may be permanent. So to the fetus and placenta, the fetal consequences of chronic placental hypoperfusion are the growth restriction and oligohydramnios. Abruptio placenta is infrequent, and iatrogenic preterm delivery is a secondary result of fetal and maternal complications. So the investigations that you do.
Before you carry on,
yes.
So can you sum for us up? How can I or how can your colleagues diagnose preeclampsia?
So how can you diagnose preeclampsia? You have to see hypertension of systolic of 140 and diastolic of 90. You have to see proteinuria of 0.3 grams. You have to see elevated liver proteins, elevated liver enzymes, and there's some classical features in the CNS such as headache and blurred vision.
So let me come in there. So preeclampsia is a whole spectrum of entity.
Yeah.
As you rightfully say, you can have the mild cases and severe cases, which I think we will discuss later. But the criteria for diagnosis is you need new onset hypertension, BPs of 140/90, more than 20 weeks, at least 4 hours apart, with either one of those things you're talking about. So you don't need them all. Yeah? Okay. The only difference will come in if you have many more of those symptoms, then you're obviously developing severe preeclampsia as opposed to preeclampsia without severe features. So it's the new onset hypertension that you've talked about, 140/90, a pregnancy that is more than 20 weeks, at least 4 hours apart, with any of those that you've talked about, whether it's proteinuria, whether it's placental dysfunction, or whether it's end organ damage in the liver, brain, many other parts.
Yes.
Carry on.
Thank you. So in the investigations, you first of all do a CBC count. So the hemoglobin and hematocrit may be elevated due to hemoconcentration, or in severe cases, in severe PT, there may be anemia. Thrombocytopenia is often present. So you also do creatinine tests. We shall see an elevated or rising level, which will suggest severe disease. You go to the liver and do serum ALT and AST. If you see elevated or rising levels, this indicates severe disease. You also do LDH concentration, and if you see it's elevated, this might show you that you have severe disease. You also do a urine dip for protein. If you have excretion of 300 milligrams or more in 24 hours, is necessary for diagnosis, or at least 1+ protein in a dipstick of 2 urine specimens collected at least 4 hours apart. If you see 3+ or greater of 500 grams, this is an indication of severe PT. You have to evaluate the fetal well-being by using an NST or a biophysical profile. In addition, you have to examine the fetus using ultrasound to evaluate growth and amniotic fluid volume. The complications of PT, on the maternal side, the immediate complications may be eclampsia if seizures develop. You have accidental hemorrhage, oliguria and anuria, dimness of vision, preterm labor, HELLP syndrome, cerebral hemorrhage, or the RDS, acute respiratory distress syndrome. During labor, you might have eclampsia or postpartum hemorrhage. During the puerperium period, you might have eclampsia, shock, or sepsis. Fetal complications, you have intrauterine death or intrauterine growth restriction, asphyxia, or prematurity. Treatment of PET.
Before you go to treatment,
yeah,
you didn't tell us how to distinguish. You said there are two categories. There are two types of preeclampsia.
yeah.
A while back, we used to call them mild and severe. But these days, we call them preeclampsia with severe features and preeclampsia without severe features. So how do you distinguish the two?
So based on...
In short, what are the features of severity?
Hypertension should be the first one.
Remember, all these patients are hypertensive. So what's the cutoff blood pressure for severity?
So for mild PT, it's 140 to 160, and above 160, it becomes severe. That is systolic, 160 systolic. For urinalysis, if the protein goes above 5 grams, it becomes severe PT. Those are the ones that I was able to pick up.
Will you allow me to pick some of your colleagues to answer that question?
Sure.
Ambani. Oh, Ambani is the one presenting. Ambani, how do you distinguish the two? And the reason you have to distinguish the two is because management is dependent on that distinction. Anyone else can answer?
I think mild eclampsia, the cutoff point is BP of 160 over 110. If it's less than that, it's mild preeclampsia, and we have no symptoms and no maternal or fetal complication in mild preeclampsia.
So I want you to list them one by one. And remember, we do not have mild eclampsia, preeclampsia without severe features. So I want you to list all of them from the symptoms to the workup and all that, so that we are all at the same page.
In severe preeclampsia with in preeclampsia with severe symptoms, there are CNS symptoms, like there's headache, there's blurry vision, then I think there's also lower epigastric pain. By the mother feels lower epigastric pain, and I think upper right quadrant pain. And also I think in preeclampsia with severe symptoms, it presents with the HELLP syndrome, which includes hemolysis, the elevated liver enzymes, and the low platelets.
Anything else? So that's good. Anything else we may have forgotten?
I think we also have disseminated intravascular coagulation. Coagulopathy.
So usually severity will either depend on symptoms, lab work, or placental dysfunction. The symptoms are the ones you've talked about. It can be in the CNS. It can be in the chest as well in terms of pulmonary edema. It can also be in terms of the epigastric pain, the right upper quadrant pain that denotes liver dysfunction as well. Then with the lab, you can talk about HELLP syndrome. So the platelets will be less than 100. The creatinine will have doubled. The STLT will also have doubled as well. Then in addition to that, you will also have elements of placental dysfunction. Either a woman will present with abruptio or with fetal demise or signs of fetal compromise from inadequate placental blood supply. So it is critical you distinguish all the symptoms. And whenever you see a woman with preeclampsia, you must ask for all this. So you must ask for the symptoms. You must order the investigations that you need. And I'm happy Kigen has talked about some of them. So you order CBC, UEC, LFTs, a dipstick, an ultrasound, and all those. All you're simply trying to do is to try to distinguish the severe preeclampsia from the other one. Then now you can discuss about how to manage, because the management for the two are totally different. Then the other thing, some will also have a different classification in terms of early onset and late onset. Yeah? The cutoff is just 34 weeks. So early onset is the one that begins before 34 weeks and results in delivery before 34 weeks. So it obviously has a much severe presentation and has a poorer prognosis compared to the late onset. Carry on.
Okay, thank you so much, Doc, for that. For treatment, we have some principles of management. So the definitive treatment of preeclampsia is to deliver a baby, to prevent further complications from developing. So whether or not to deliver, sorry?
Before you carry on, is that statement true?
According to some books, yes.
Okay, on the left.
So whether or not to deliver is based upon the gestational age, both the maternal and fetal conditions, and severity of preeclampsia. So the primary objective is safety of the mother and then delivery of a healthy newborn. So the first thing that you have to do is, because one of the conditions of preeclampsia is hypertension, the first thing is you're supposed to stabilize the blood pressure. So to stabilize blood pressure, we normally use, in MTRH, we normally use hydralazine, ifedipine, methyl-dopa, labetalol, or atenolol. You can also use non-pharmacological therapy, such as having bed rest.
Hydralazine.
Yeah. Okay, mostly it's nifedipine.
So normally it will depend on how bad the pressures are, as you rightfully said, the severity. If you're dealing with the 160 over 110 and more, those are very high pressures that you need to bring them down acutely. So for acute management, the options are the hydralazine, nifedipine, or labetalol, or other agents, but those are the common ones that are used for acute control of severe blood pressure. Then if the pressures are not so bad, then methyl-dopa is also an alternative in addition to all those other drugs you've talked about. Remember, hydralazine is given intravenously. Labetalol is also given intravenously. And you have to be cautious about, because they are very dangerous drugs. They can lower the BP excessively and result in not so good outcome. So there's a way in which they are administered and they must be monitored.
Yeah.
Okay, carry on.
So the next thing is you want to prevent eclamptic seizures. So you use magnesium sulfate, and there's a table here showing about magnesium sulfate. So if it is a seizure prophylaxis, this is in the protocol. You use a loading dose of 4 grams and maintain using 1 gram hourly. If it is a seizure treatment, you use a loading dose of 4 grams and give 2 grams every single hour. So to monitor, you're supposed to check for the respiratory rate, pulmonary exam, and to monitor the urine output. And you also have to check for patellar reflexes.
Why are
If
you
you
doing all this?
to check for toxicity of magnesium sulfate.
Continue.
Yeah, if you suspect magnesium toxicity, you give calcium gluconate, which is the what is it called? You give calcium gluconate. Yeah. So the third thing is you monitor maternal well-being by measuring the BP, and also you check the input-output chart for fluids. You also request for urinalysis, check for urea, creatinine, and creatinine levels. Also do liver function tests and CBC. The fourth thing you do is monitor the fetal
Sorry,
well-being.
Dr.
Yes.
I just remembered that I should have asked you this. How long do you give them magnesium sulfate? That's a common question can be asked in the exam.
Okay. Okay, I'm not
Or
sure.
anyone else can answer. So you give for at least 24 hours post delivery.
Okay.
So if you've delivered today at 5 p.m., you have to give till tomorrow at 5
Tomorrow, 5 p.m.
5 p.m. Remember, postpartum eclampsia is more common than even antepartum eclampsia.
Antepartum.
For at least
Okay.
20.
Yeah. So the fourth one was to monitor the fetal well-being. So in this, you check the fetal heart rate, the fundal height, fetal kick charts. You also check for the physical profile. You do it with Doppler studies, and you check for the fetal ultrasound to examine fetal growth. Yeah, and so the algorithm for mild preeclampsia, for treatment of mild preeclampsia, is this was from the protocol. So mild preeclampsia, we have BP of less than 160 over 110, showing no symptoms and no maternal fetal complications. So you do the maternal assessment. We've mentioned BP, input output chart, urinalysis, urea electrolytes, creatinine, the liver function tests, and CBC. You also do fetal assessment. You do fetal heart rate monitoring, fundal height monitoring, the daily fetal kick chart, ultrasound biophysical profile with Doppler studies, and you also do the full obstetric ultrasound. So if maternal and fetal status are stable, you discharge home with precautions. If maternal or fetal heart rate worsens, you manage as severe preeclampsia. So when you discharge the mother, you plan for delivery at 38 weeks. For severe preeclampsia, which is BP of greater than, yes.
Doctor, let me add something. It's a very good algorithm to have and it will help you a lot. So the only thing I need you to take note of is how often we do the assessment, whether it's maternal or fetal. Just take note of that. Whether it's weekly, 3-4 weekly, and all that. Okay.
Yes. So for severe preeclampsia, severe preeclampsia, the BPs are normally above 160 systolic or 110 diastolics. The patient presents with symptoms and lab abnormalities. So before you do anything, you're supposed to stabilize BPs and draw labs and also start magnesium. So as a prophylaxis to the seizures, if the fetus is alive, below 24 weeks, you cancel the family and maybe terminate the termination of pregnancy. If the fetus is between 24 to 28 weeks, you assess fetal well-being. If it's below 100 grams, you cancel the family to terminate the pregnancy. If it is above 1,000 grams,
sorry, Doctor, can I come in again? I'm sorry, I'm
Yes,
interrupting you.
Sure.
But it's easier so that I don't forget. Do you know
Okay.
the reason we terminate for these early onset PET, preeclampsia and all that?
Yes, to prevent further complications.
Right. And usually this disease is a progressive disease, especially once
Yes.
it begins early, it will progress quickly, it will progress early, and most of the time the pregnancy will not even reach viability without having those symptoms of severity. So it is, upon discussion with the patient, a reasonable option in early onset preeclampsia. Carry on.
Okay. Okay. So if the fetus is above 1,000 grams, you administer corticosteroids, and you manage until 34 weeks, and you plan for delivery at 34 weeks. If the fetus is between 28 and 34 weeks, you assess for well-being and administer corticosteroids also, and plan for delivery at 34 weeks. If the fetus is above 34 weeks, you assess the fetal well-being and plan for delivery. The other side, which is not so clear, this is fetus alive, and the other side is fetal death. If there's a fetal death, you have to induce labor. So we have some indications for delivery for severe preeclampsia. The maternal side, you have 34 completed weeks, uncontrolled blood pressure on 2 agents at maximum doses. You have platelets less than 100,000. You have liver enzymes, which are 3 times normal. You have deterioration in renal function, such as you're supposed to see elevated creatinine, oliguria, and anuria. You have persistent severe headache or visual changes, persistent severe gastric pain or nausea and vomiting. And you also do delivery if there's a suspected abruption. For the fetus, you deliver if there is intrauterine growth restriction, the biophysical profile of 4/8, oligohydramnios and anhydramnios. You have Dopplers with absence and diastolic flow.
Before you carry on, what are the other indications for absolute delivery, irrespective of gestational age?
We talked about
before you
fetal
answer,
death.
let me just summarize so that we are all on the same page. If you're dealing with preeclampsia without severe features, you rightfully said, if all the investigations are okay, then you have a chance to continue with the pregnancy until viability or until features of severity develop. If you're dealing with severe preeclampsia, then you're trying to push the pregnancy to at least 34 weeks. Yeah? But at any one point, you must do those assessments. If there is any signs of severity, then delivery becomes most of the time inevitable. But there are those indications for complete delivery, irrespective of the fetal status or gestation. Which ones are they? One of them is on the screen. What are the others?
We also mentioned the fetal death.
Yes.
If the fetus is alive and less than 24 weeks.
No, not necessarily. What are the absolute indications for delivery in preeclampsia?
Apart from the ones in the screen.
Yes. I believe in this screen, you're summing up HELLP syndrome. That's one of them. HELLP syndrome. What's the other? That affects the lungs.
Pulmonary edema.
Pulmonary edema is an absolute indication for delivery of the lung. Okay, continue.
Okay, so we go to eclampsia. So eclampsia occurs in 0.2 to 0.5 of all deliveries, with occurrence being influenced by the same factors as in preeclampsia. about 75% of eclamptic seizures occur before delivery. And for the postpartum ones, 50% occur during the first 48 hours after delivery. So the pathophysiology, seizures have been attributed to platelet thrombi, hypoxia, due to localized vasoconstriction and foci of hemorrhage in the cerebral cortex. There's a mistaken tendency to equate eclampsia with hypertensive encephalopathy. So the clinical findings, there is usually no aura preceding the seizure, and the patient may have one or two or many seizures. And consciousness lasts for a variable period of time. So how it occurs, the patient hyperventilates after the tonic-clonic seizure to compensate for the respiratory and lactic acidosis that develops during the apneic phase. Fever is rare, but is a poor prognostic sign. Seizure-induced complication may include tongue biting, broken bones, head trauma, or aspiration. Pulmonary edema and retinal detachment have also been noted following seizures. So treatment of eclampsia. So the first thing, you are supposed to prevent maternal injury. The second thing is to do ABC, that is to protect the airway and oxygenation, to ensure that breathing happens, and to check for circulation. So management may include placement of a padded tongue blade and suctioning of the oral cavity. You're supposed to check for pulse oximetry. After that, after the mother's condition is stabilized, you check for fetal monitoring. So to stabilize the seizures, you use magnesium sulfate. Only when the mother is safe, you can undergo surgery, and if CS is not indicated, a vaginal delivery should be attempted. So to prevent convulsions, the loading dose is normally 4 grams of magnesium sulfate, solution IV over 5 to 10 minutes, following promptly with 10 grams of 50% solution, 5 grams in each buttock as deep IM injection. Then if convulsions occur, you give 4 grams magnesium sulfate over 5 minutes. To maintain, you give 5 grams every 4 hours. So before giving the dose, you have to check for magnesium toxicity. So you check for the respiratory rate, which should be 16 per minute or more. You check for the urine output, which is 120 mils in the last 4 hours, which is 30 mils per hour. You check for the patellar tendon reflexes. So if these 3 conditions are unsatisfactory, you delay or withhold and give calcium gluconate, which is the antidote, until respiration improves. So we already talked about this. So for the management.
Sorry, let us go back. Back a slide. The magnesium sulfate usually comes in different formulations. There's this 20-50%. The one you give IM every 4 hours is a different formulation that you will find once you start practicing in the villages. But the one we use in our setting is the 20%, where you give 4 grams IV over 5 to 10 minutes. Then you just give a gram an hour till the time that you want to stop, what I've talked about. The monitoring remains the same. They like asking these cutoff for stopping magnesium sulfate, respiratory rate, urine output, patellar tendon reflex. So it's worth taking note of, and as well as taking note that you can use calcium gluconate as an antidote for the same in case any of these is deranged.
Okay, so for eclampsia, during the intrapartum stage, so the first stage you monitor. In labor, you use the pathograph and you check for vital signs after every 30 minutes. You check for urine and output and proteins and fetal heart rate every 15 minutes. For the second stage, you shorten it as much as possible by use of a vacuum delivery. The third stage, you are not supposed to use egometrin as it's contraindicated, and you're supposed to actively manage the third stage. So we have a chart here for management of eclampsia, as we've talked about. The first thing you do is check for the ABCs, airway, breathing, and circulation. You brief maternal fetal assessments. You start on magnesium sulfate, loading dose, then you give the maintenance dose. You're supposed to stabilize blood pressure by using hydralazine or the other hypertensive drugs. You check for labs, the CBC, EUC, liver function test, and coagulation test. Then you evaluate for induction of labor. If the Bishop score is greater than 5, you induce labor as per the protocol and deliver within 12 hours. If the Bishop score is less than 5, you plan for CS after the Bishop score is stabilized. And yeah. So we go to chronic hypertension in pregnancy. Yeah.
So you go to that. Do we agree that the best mode of delivery for these women is a vaginal delivery? Do you agree with me?
Unless there's any other contraindication, yes.
So the best is usually vaginal delivery. If you can achieve it within a reasonable time limit, then even if sometimes later on you learn this, that even if the os is closed and sometimes you can induce their labor, and luckily women with eclampsia usually progress really fast. You'll see these once you start. You'll see these once you start practicing. So ultimately, most of the time, the best mode of delivery is a vaginal. Unless there's an obstetric indication.
Okay. So we go to chronic hypertension in pregnancy. So we have in chronic hypertension in pregnancy.
Sorry, Dr. Before you go,
yeah.
Are there ways you can prevent pre-eclampsia in women?
Yes, you give aspirin preconception.
How much, for how long, to which kind of women? Okay, you will check that.
Didn't check. Okay. I can go on. Or...
Yes, carry on.
Okay, thank you. So chronic hypertension in pregnancy. So chronic hypertension is high blood pressure with systolic BP equal or more than 140 systolic or 90 diastolic with or without proteinuria, which happens before pregnancy or prior to 20 weeks of gestation, and it often persists more than 12 weeks postpartum. So the incidence of chronic hypertension varies among different populations, ranging from 0.5 to 4%, and the average is around 2.5. So it's normally idiopathic, but it can also be caused by renal disease. So a number of renal diseases that can cause it is chronic glomerulonephritis, interstitial nephritis, diabetic glomerulosclerosis, IgA nephropathy, and renal artery stenosis. So the signs and symptoms, you have patients with chronic hypertension tend to be over 30 years of age, obese, multiparous with associated medical problems such as diabetes or renal disease. The patient has hypertension without other signs of preeclampsia, example, proteinuria or non-dependent edema. The diagnosis is made on the basis of documented hypertension before conception or persistence of hypertension after the puerperium period. So for investigations, you do an ECG, which shows left ventricular hypertrophy, which can be in 5 to 10% of patients. You do creatinine levels, which shows elevated serum creatinine due to decreased creatinine clearance, and proteinuria is present in 5 to 10% of patients. You also do a chest X-ray, which shows cardiomegaly, and also actually, that's it. So for the complications, you have maternal and fetal complications. So the main complication of chronic hypertension is superimposed preeclampsia, which occurs in about 1/3 of patients. The patients tend to deteriorate faster with superimposed preeclampsia than with preeclampsia alone. There's a risk of placenta abruption with chronic hypertension. And there's also the risk of DIC, acute tubular necrosis, or renal cortical necrosis. The fetal complications, we have prematurity and intrauterine growth restriction. Preeclampsia tends to occur after 34 weeks gestation, so that prematurity is not of great concern. Preeclampsia superimposed chronic hypertension occurs earlier at 36 to 34 weeks. And in such cases, the fetuses are 2 times at risk for prematurity and IUGR. There's also a risk for stillbirth and interpartum fetal distress, which is caused by the placental abruption or chronic intrauterine asphyxia. So treatments, you have to, one of the principles is to stabilize diastolic blood pressure to be below 110. To monitor for superimposition with preeclampsia. The third thing is to monitor maternal and fetal well-being. And the fourth thing is to terminate pregnancy at optimal time. So we have 2 times. We have the mild and severe. So in mild hypertension, if the patient comes in as an outpatient, you first of all advise on rest, physical and mental. You advise on low salt diets. You also carry out routine ANC profile with every visit. In obstetric management, you await for spontaneous labor and terminate if labor does not occur in 40 weeks because there's a risk of stillbirth. In severe hypertension, you have to admit and monitor and control blood pressure with antihypertensives. You also monitor for fetal and maternal well-being and carry out the various tests such as CBC, proteins, the liver function test, uric acid, and you also do the fetal kick chart. So if there's good BP and no end organ damage, you continue pregnancy until term and await spontaneous labor. And if labor does not occur after 40 weeks, you terminate. You deliver vaginally.
Wait. Yes. Terminate if labor doesn't occur in 40 weeks. I hope you mean deliver.
Yes, deliver, sorry.
Terminate means you don't
stop.
care about what happens to the baby. That's what it means in obstetrics. Okay.
Yeah, so you deliver vaginally unless there's a contraindication. And yeah, if it is poorly controlled, you follow the protocol for preeclampsia. And if there is superimposition with preeclampsia, you also follow the protocol for preeclampsia. We go to gestational hypertension. We're almost done.
Before you carry on,
yeah,
I have several questions for the group. We can start with Farida. I am picking randomly. When is the ideal time to meet these women who have chronic hypertension? When would you want to meet them, ideally, as an obstetrician?
Their first visit to the clinic after the previous pregnancy. I think. Hello.
Anyone else with a different opinion?
I think the best time to meet them. I think the best time to meet them is before conception.
Why? Anyone can try to answer. Why would you want to meet them? Actually, that's the answer. You should ideally meet them before they conceive. Why do you want to meet them before then?
It's just a thought, but I think when you meet them before conception, you can try first to regulate the pressures.
Good.
Then also you can
Good pressure control, yes.
Yeah. Then also you can try to prevent PET. That's by giving them low dose aspirin before 12 weeks.
So aspirin is given after 14 weeks. Given
okay.
Second trimester and beyond.
Okay.
But what else do you want to screen from them so that you ensure the pregnancy outcome is optimal? So you want to screen them for end organ damage, the ones Dr. talked about. You want to do an echo ECG, you want to do UECs, you want to do all those things that chronic hypertension, all those organs that chronic hypertension can damage. Then the final thing you want to do, most patients with chronic hypertension, you'll agree with me, are on drugs that we don't use in pregnancy. So what would you want to do for them, Victor, Kigen, regarding these drugs? Which are the drugs that are contraindicated, the antihypertensive contraindicated in pregnancy?
I think the first one should be ACE inhibitors.
Yes.
We have the diuretics.
Okay, yes.
Those are the ones that I can think of on top of my head.
So, and also the ARBs as well, they go hand in hand. Those are not used in pregnancy, as well as if they are on the beta blockers, also those ones most people would commonly want to stop them because of their association with fetal growth restriction. Yeah? So preconception for these women is very critical to ensure that their BPs are well controlled, to ensure there's no target end organ damage, and to also ensure that you adjust their medication appropriately. Then thereafter, once they get pregnant, you'd want to meet them within the first trimester for their first prenatal visit. Carry on.
Yeah, thank you. So we have gestational hypertension. So gestational hypertension refers to hypertension with onset in the latter part of pregnancy, which is after 20 weeks, without any other features of preeclampsia, followed by a normalization of blood pressure postpartum, which is before on or before 12 weeks. The signs and symptoms are hypertension, edema, sudden weight gain, blood vision, and headaches. For treatment, you control the blood pressure. In HELLP syndrome, the HE stands for hemolysis. No, the HE stands for hemolysis. The EL stands for elevated liver enzymes, and the LP stands for low platelets. This is a severe variant of preeclampsia. We have platelets less than 100,000. So for management, you have to immediately hospitalize, stabilize the mother by giving antihypertensive drugs, anti-seizure prophylaxis, and you have to correct the coagulation abnormalities. You also assess fetal conditions by doing Dopplers, by physical profile, and fetal heart rate. The last one is chronic hypertension.
Go back to the previous slide. This is discussing HELLP syndrome.
Yes.
What have you forgotten in this? But it's critical. One word that you've forgotten in the last in an extra bullet you would want to add here.
In management.
Yes.
Deliver.
What did we say? Yes, you must. Actually, it should be in capital. You must deliver these women after all these things you've done, irrespective of the gestational age.
Okay.
Then the other question I had for you, I saw in the gestational hypertension you talked about edema. Is edema a requirement for hypertensive diseases in pregnancy? You also mentioned it in pre-eclampsia.
Yes. It's not a requirement, but because like a lot of women in pregnancy come with edema.
So it is not a requirement. So some women can have, some women will not, but you will not, you should not demand it for you to diagnose either of these conditions. Okay, continue.
So we have chronic hypertension with superimposed preeclampsia. This condition occurs in women who have been diagnosed with chronic high blood pressure before the pregnancy, but then develop worsening high blood pressure and protein in urine or other health complications during the pregnancy. So the causes are essential hypertension, which is basically chronic hypertension. Then you have chronic renal disease or coarctation of the aorta, and we have connective tissue disorders such as SLE. Diagnosis, you check for new onset of proteinuria, aggravation of hypertension, development of HELLP syndrome, and development of headache and epigastric pain. For treatment, you follow the protocol of PET. Thank you.
Thank you, Dr. for the great presentation.
I think there's a question in the chat. There's a question in the chat. Nicholas is asking, which is the most common cardiomyopathy in PT and how is it managed? I think I might have read about left ventricular hypertrophy. Maybe Doc, you can help.
What did you find out? These cardiac problems really commonly associated with preeclampsia?
Not really, but maybe left ventricular hypertrophy. I'm not so sure.
You see, preeclampsia is a short-lived pregnancy-related pathology. The only issue that usually comes is the long-term risk that it gives you in women of developing these cardiovascular problems later on in life. In fact, some people say those who have PET, women with PET, will live 10 years less due to complications of either developing hypertension later on in life or one of those cardiovascular problems. So it does not commonly result in cardiomyopathy. Personally, I have not seen PET patients having clinical cardiomyopathy. Any other questions? If not, I have a case for you to
There's
answer.
a question in the chat. There's a question in the chat. Can PET occur before 20 weeks and what are the causes?
You should answer that one.
I think from the definition itself of PT, this happens after 20 weeks. So if there is high blood pressure before 20 weeks, that could be termed as chronic hypertension, I think.
Good. So PET must be after 20 weeks. Any other questions? So let me read for you this case. I hope everyone is paying attention because the answers will come randomly from any of you. So assume you are working at Mosoriot Health Center. It's a health center that is providing outreach services. The MCH nurse calls you to see a pregnant woman with a BP of 160/110. So you're working in Mosoriot, it's a health center, you're doing outreach services. You're called to see a pregnant woman with a BP of 160/110. So what are some of the things you want to know about her? Winnie Elizabeth. What are some of the clinical things that you want to know about?
So I want to know how the gestation by date, and if there is a prior history of hypertension before this presentation.
You don't want to know her age parity first?
Oh yeah. I want to know the age, the parity, the gestation by date, and
Do you
if
want to
there's
know the gestation by date, or you want to know her LMP so that you calculate the gestation by date and the EDD?
Yeah, ideally you get the LMP, then you calculate the GBDD.
Good. Mm-hmm.
Yeah, then I want to know if they have had a prior history of high blood pressures before, and if they are on any medications for hypertension.
Good.
And I want to know if they have any associated symptoms, symptoms associated with these high blood pressures. So like headache, blurry of vision, any other signs of PET. So headache, blurring of vision, abdominal pains, right upper quadrant pain, any changes in urinary habits.
Good. Anything else you want to know?
If they have any seizures.
Okay, yes.
I'm not sure of any other thing.
Aisha Mahmood. Any other thing she may have forgotten? So you'd also want to know whether she's begun an antenatal clinic, right? And of course, the other routine things in the history, the past medical history, surgical, the medication she's on, allergies and all that. Eh? So listen carefully, because the next question will go to Wendy. So this woman is 18 years. Eh? It's her first pregnancy. She's 32 weeks by her date. Then on top of that, her pregnancy has been uncomplicated so far. This is her first antenatal visit. She has never had an ultrasound for this pregnancy. She's very sure of her date. With regarding symptoms, she had a dull headache yesterday. No visual changes, no abdominal pain. She's perceiving fetal movement, but she's generally not feeling not so well today. But otherwise, she's healthy. She has no allergy, she doesn't smoke, and there's no relevant history in her family or medical or surgical history. What are the things you want to look for in a physical exam? What are you interested in her physical exam?
Could you please repeat the symptoms that she presented with?
Yeah, sorry.
Please repeat the symptoms that she presented with.
You've just been called to see a woman in Mosoriot Health Center. She's 32 weeks by date, uncomplicated pregnancy so far. The only thing is her BP is 160 over 110. The only complaint she has is a dull headache yesterday. No other symptoms. She's perceiving fetal movements well, but she just feels generally unwell today. So what are you looking for on physical exam? Or what are you interested in on physical exam?
On examination, I would want to determine the fundal height to see whether there is any, okay, considering the fact that the pressures were that high, I'd like to establish that there is no other accompanying symptom like abruption, which would increase the fundal height in case it is present.
Allow me to ask, when you're examining anyone, what do you begin with?
I'd also check for the heart rate. Yes.
So you begin with a general exam, right?
Oh, yes, 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 to determine whether there's any other presenting symptom that might be hidden.
So I am waiting for 5 points in the physical exam. You said fundal height, right? What else?
Pardon?
I am
Yes,
waiting
I said
for
fundal
5.
height.
Fundal
I said
height.
fetal heart rate.
Yes.
Fetal heart rate.
Good. What else?
The presentation of the fetus.
Okay. Yeah. What else?
Whether the fetus has engaged into the pelvis.
Okay. You'll do an abdominal exam. What else would you do?
In terms of physical examination, maybe someone can help me.
Mariam Farid.
I'd also like to do a CNS exam.
Good. Yes. What are you looking for?
So you want to look for any signs of, because of the high BPs. So your vision, yeah.
Anything else other than the CNS exam? So let me give you the answer. What I would want to do, I would want to begin with a general exam. I confirm the vitals, right? It's what we do for all patients. The vitals, you confirm the BP. Then you want to comment on the general status of the patient, just like in any general exam. Then now you want to go to the system. You want to examine the chest, the respiratory, the cardiovascular, right? Then you want to go to the abdomen. You rightfully put it, the fundal height, the fetal heart rate, are there contractions or not? And specifically in the CNS, you should also be interested in the reflexes. Remember, this is a pre-eclampsia patient. Are we okay on that? So the general agreement is that for pre-eclampsia patients, you must do a full medical exam from the general to most of the systems. So Dennis Kamuri, listen to this. This same woman has a BP of 160 over 110, a pulse of 92, a resp rate of 14. She's in fair general condition. Head and neck exam are normal. Chest exam is normal. There's slight tenderness on the right upper quadrant. Are we clear? The reflexes are okay bilaterally, but her fundal height is 28 weeks. There are no contractions. There is a fetal heart rate. What are your likely diagnoses? What is your diagnosis? 2 diagnoses you would entertain. Or let me pick someone else. Melan Sawe. What are two of your differentials or diagnosis in this woman? Kigen, you want to take one for the team? Or anyone? What are the likely diagnoses?
Okay, I can try.
Yeah.
I'm thinking of
Because of the right upper quadrant tenderness, I'll think of HELLP. Then
Okay.
the fundal height being 28 weeks, yet the mother is sure that she's at 32 weeks. I'll think of intrauterine growth restriction.
Good. The last one, what else? The obvious one, the obvious diagnosis.
PET.
PET or pre-eclampsia with severe features? So whenever you're diagnosing PET, you must be clear. Are you dealing with the severe one or the one that is not severe? Okay, those are our possible diagnoses. So the next question is, what is your management plan? Remember, you are in Mosoriot Health Center. What is your management plan? Sam Kioko.
Well, considering we're in Mosoriot, it goes without saying that they won't have as good a medication stock or facilities to go forward. So we're doing all of this with the eventual plan to refer to MTRH. But the first thing you do in this situation, in my opinion, would be we need to lower her BPs. So I'd be looking at nifedipine, start her off at 20 milligrams, start. And since my medical knowledge seems to have be deficient in terms of how to move from that point on, but it's a matter of lowering her BP. Start off with nifedipine. I'd appreciate help from that point.
So you're actually right. The ultimate thing is to have a referral. And the reason you're referring is because most likely you're going to deliver this woman. She's 32 weeks. There's no NBU in Mosoriot, right?
Yeah.
So referral to MTRH probably. So you've seen her in MTRH. This is for someone else. The question. Let me pick Ronald Kibet. So you've seen her in MTRH. What investigations do you want to order for her? What investigations do you want to order for her?
Okay, I think first of all, I'd order for UECs.
UECs?
Urine analysis.
Okay.
LFTs.
Yes. Anything else? Tabitha, anything else?
An abdominal ultrasound.
Laboratory investigation.
So CBCs as well.
Good. You want to do a CBC. Anything else? A coagulation profile. Some people will want to do other investigations, but those are the main ones. CPC, LFTs, urinalysis, UEC, acquired profile, and some will even want to do uric acid levels for this same woman. So I have a set of results here. Her HB is 8. I hope you all know the normal HB. So it's lower. Her HB is 8. Her platelets are 86,000. Then in the UECs, her creatinine is 88. It is still within normal. Her ALT and AST are 4 times the normal. Are we okay? In her urinalysis, there is proteinuria +3. Her coag profile is basically normal. What next? Samantha Koech, what is your most likely diagnosis now? One word. What is your
My most likely diagnosis will be severe pre-eclampsia with severe symptoms. Or HELLP syndrome.
HELLP syndrome. That's the answer. HELLP syndrome. Because of the low platelets and because of the elevated liver enzymes. And remember, I said the HB is 8. So there's hemolysis happening. That's why the HB has gone to 8. So this is a classical syndrome patient. So again, you're still in MTRH. You decide to evaluate the fetus. So the patient does an NST, a non-stress test, which is non-reactive. Which 2 tests would you recommend? So you've met her, you've done the lab work, you've taken her for an NST, you found that it is not reactive or it is non-reactive. Which 2 additional tests are you going to recommend? Kipkoech Edgar. John Maore. Which 2 tests are you going to order?
I'm not sure, maybe ultrasound.
And what are you looking for in that ultrasound? You're actually right.
Maybe oligohydramnios, or maybe
yes, oligohydramnios. What else? What do we call that profile that has oligoamniotic fluid?
amniotic fluid index.
There's a profile that has several components. One of them includes the level of amniotic.
Okay, biophysical profile.
Yes, a biophysical profile. Anything else?
Doppler.
So it's a biophysical profile and a contraction stress test. You will go check what a contraction stress test is.
Okay.
So subsequent to that, the next question is, what are the components to a biophysical profile? That's the first question. What are the components to a biophysical profile? Up to how long can it last to achieve all components? Hilal. So you'll get 1 mark for stating the components and an extra mark for saying what are the requirements for that particular component. So what are the components? Anyone knows who wants to try? One of them is obviously amniotic fluid, which Maure had mentioned. You will check the others and how we do it.
Fetal
What are the
tone, fetal movements, fetal
all
respiration, then
movements?
amniotic fluid volume.
Good. So the amniotic fluid, tone, movement, and breathing. All are 4. So how is it done? What do you need to? Do you know how we give marks or points? Okay, the last question. Her biophysical profile is 6 out of 8. How will you manage this patient? Her biophysical profile is 6 out of 8. How do you manage this patient? The last question must go to the presenter. Victor Kigen. Her biophysical profile is 6 over 8. How will you manage this patient? Or anyone else? I can give you one answer. I would admit the patient first. What else?
Could you give the mother dexamethasone shots to mature the lung before you schedule a delivery based on the results you find from the contraction stress test to know which mode of delivery you will
So are you
use?
giving or you're thinking about giving or you must give? Which is?
I will. Okay, since the BPP is 6 over 8, I will give dexamethasone.
Good. What else would you want to do for her other than admission and the steroids for lung maturity? It's the reason we were having this class.
Another thing
What's
you'd
the
like to
first
do
thing you
is
want to do?
The BP.
Exactly. You want to control the BPs with what? Antihypertensive medications, which Victor Kigen has talked about. Any other thing?
Of course, you'd like to plan for delivery.
How are you going to deliver the baby?
Vaginally, unless
Remember the
there's
BPP, the BPP is 6 over 8. Huh?
Mhm.
So how do you want to deliver her?
I think vaginally, because less than 5 is yes, so vaginally. So,
What else? So that we are clear, what's the indication for delivery here? Kigen, this is your question. What's the indication for us delivering here in this patient?
the HELLP syndrome.
Exactly, HELLP syndrome. So delivery is indicated here, and due to reasons that you fear about compromised fetus, you can consider a cesarean delivery. What else? Anything else? What's the last thing you'd also want to do? Which you say
Sulfate.
exactly, you have to give magnesium sulfate as indicated. And that's the end of my question. And that's the OSCE one of your groups did last time, and it ended there. Any other question? Any questions from the group? And there's a very good question asked there. the general rule you should go with here. All seizures in pregnancy are Kigen.
Yes.
All seizures in pregnancy are
Eclampsia.
until
proven, yes.
So all seizures in pregnancy are basically eclampsia until proven. Because someone had asked this question on, let me read it. How to differentiate eclampsia from seizures due to hypertensive encephalopathy. You hardly get a hypertensive encephalopathy in pregnancy. So whenever you have altered consciousness in pregnancy in a woman who is feeding, it is simply eclampsia, which you must treat with magnesium sulfate. You control the BP, and the definitive treatment is Kigen. The definitive treatment is
delivery.
Delivery. Any other question or additional comment? So as you can note, no one will ask you things that are foreign. It's just things we have discussed here, and it's the basics of preeclampsia and these hypertensive disorders in pregnancy. So go read about the components of the biophysical profile, how it's done, for how long it's done, and how to interpret the values 6/10, 8/10, 10/10, 6/8, or all that. Yeah. I think we can call it a day. Kigen, you can close the meeting.
Okay, thank you.
All the best.